Hello everyone, I am Dr. Ahmed D. Abdulwahab and this is Highlights in Radiology. Today we have a bit of a big episode. It's a topic that is very important. It is so necessary in deciding the proper management of the patient, and our knowledge about it is not that much. And in fact, I chose this topic because one of my very respected colleagues suggested to me that we do an episode on that. So I might take a little bit more than usual of your time, but I would recommend that you see this episode till the end because of its clinical significance. Today we are going to talk about the MRI of placenta accreta spectrum. So first of all, let's start by defining the placenta accreta. What's a placenta accreta and what does it mean? A placenta accreta is an abnormal trophoblast invasion of part or all of the placenta into the myometrium of the uterine wall. So basically, the placenta is invading the myometrium and maybe even the surrounding tissues abnormally. Why do we call it placenta accreta spectrum? Well, because the depth of invasion of the trophoblast of the placenta into the myometrium is variable. So it's like a spectrum. So we divide it into placenta accreta, increta, and pericreta, and we'll know the difference between them in the coming slides. So let's start with the most common, basic, and primary diagnostic tool, that is the sonography. How we should suspect presence of placenta accreta spectrum using sonography. If we see a low-lying placenta or placenta previa in a woman with a previous cesarean delivery, we must do a follow-up examination at 32 weeks of gestation. And at that 32 weeks of gestation, we look for specific signs. So what are the signs that we look for it? First of all, we look for any presence of placenta previa, as we can see here. This is the placenta, and this is the cervix, and this is the cervical canal, and you can see the placenta is completely covering the cervix, indicating a placenta previa. That's suspicious for placental invasion of the myometrium. If we see abnormal prominent lacunae, like you can see here, these are very big lacunae within the placenta. So these are suspicious. If we see abnormal color Doppler signal intensity, and you can see here in the ultrasound exam, there are prominent lacunae here and there, and when you put a color Doppler, it's markedly increased vascularity all over. So this is very suspicious of placental invasion. And loss of the retroplacental clear space. Personally, I think this is not something easy to estimate. So we should be careful with that. You can see normally there is this placenta and there is this retroplacental clear space. While here the placenta looks good here, and then suddenly there is loss of the retroplacental clear space here. So this is a suspicious pattern for placenta accreta spectrum. Also, if there is reduced myometrial thickness, which is logical because the placenta is invading into the myometrium, you can see here there is a normal myometrium, while here the myometrium is very thin and irregular, and it's basically not as normal as it's supposed to be. This is suspicious. And finally, we should look for any irregularity of the urinary bladder wall. If we see this irregularity of the wall of the urinary bladder, it means that probably you have placenta pericreta. The placenta has invaded the myometrium and now it's invading the adjacent organs. So these are the features in sonography. Now, let's talk about the types of the placenta accreta spectrum, or the grades, let's say, of the spectrum. We have the placenta accreta, placenta increta, and the placenta pericreta. First of all, normally the placental villi are just like that. They are in contact with the myometrium, but they are not adherent to the myometrium. Now, in placenta accreta, the villi are attached to the myometrium. They are adherent to the myometrium, but they do not invade. Like here, you can see this is the myometrium, and the villi, placental villi, are just attached to it, adherent to it, stuck to it. Okay? If the villi are starting to invade the myometrium, but not invading the surrounding tissues, like here, you can see the villi are invading, this is the normal myometrium, while here they are invading the myometrium completely, but not the surrounding soft tissue. This is placenta increta, okay? Now, the most severe form is the placenta pericreta, in which the villi have invaded the entire myometrium and now they are extending to the surrounding soft tissues. This is placenta pericreta, okay? So these are the three types that forms the placental accreta spectrum. Now, our main topic is the MRI of the placenta. What do we look for when we do an MRI of the placenta to detect placenta accreta spectrum? First, let's know what's the normal placenta. The normal placenta should be uniform in thickness, like in here, you can see the uniform thickness of the placenta, okay? It's about 2 to 4 centimeters at its mid portion. The external contour should be smooth, okay? The thickness gradually tapered at the edges. You can see at the edges here, the thickness of the placenta gradually tapers, okay? The maternal surface of the placenta might contain some placental lobules, which are outpouching of the placental tissues with some septa here and there. And these septa are normal findings, and they are visualized on T2-weighted MRI images as a subtle thin bands of T2 signal intensity. You can see here, these are very subtle T2 bands. These are normal findings of normal placenta. Let's see, in this example, this is another case. We can see here that this is the normal placenta, and this is older older pregnancy, let's say more gestational week. And as we go further into pregnancy, the placenta becomes more heterogeneous. At the beginning, it's homogeneous, and then becomes more heterogeneous. So this is a slightly more heterogeneous placenta. You can see the septa here and there, and you can see some placental outpouching or lobules here and there, and you can see there's areas of signal hypointensity at the base representing a normal vascularity of the placenta. And again, another example, we can see here that this is a smooth placenta with tapered edges here and there, okay? And you can see some flow voids in the normal placenta. Now, in MRI of the normal placenta, we should know how to differentiate the normal placenta from the normal myometrium. So the normal placenta has an intermediate signal intensity. Like you can see here, it has this intermediate signal intensity, while the myometrium, it's usually clearly distinct from the placenta, and because it has more heterogeneous and more hyperintense signal. And here we have a very important point to consider. Before 24 weeks, the placenta is not mature enough. So its MRI performs poorly before 24 weeks of gestation, while after 30 weeks of gestation, the placenta becomes more heterogeneous and irregular. So the best time to image the placenta is between 24 to 30 weeks of gestation. It's the best time, 24 to 30 weeks of gestation. The uterine myometrium will vary in appearance throughout pregnancy. If less than 30 weeks, it has an appearance of 3 distinct layers. And we can see here, it has a hypointense inner and outer layer and a hyperintense middle layer. As you can see, I will show you other example. You can see here, it has a hypointense inner layer, hypointense inner and outer layer, and hyperintense middle layer. And as the pregnancy progresses, the middle layer will become even more hyperintense, more bright. The myometrium normally contains multiple flow voids, which is a normal vascularity. You can see here, there are these hypointense flow voids. And as the pregnancy progresses, the layers will be less distinct. Another example here, you can see this is a smooth placenta, smooth tapered edges. There are some lobules here and there with thin septi, and you can see that as the pregnancy progresses, this is a rather progressed pregnancy, and you can see it's less, the layers of the myometrium are less obvious than the earlier in pregnancy. That's why we would recommend to do the MRI in suspected cases between 24 to 30 weeks of gestation. So, if the placenta is invading the myometrium, what should we look for? The basic pathology is that the placenta becomes tethered, it becomes attached to the myometrium. So as the pregnancy progresses, it will not be able to migrate, to move. And this will result in most of the imaging features that we look for. So, the placenta will have a lumpy contour and rounded edges. You can see the edges here are a little bit rounded more and lumpy because it's adherent. And it has, of course, placenta previa, which was the main feature to distinguish or to suspect the presence of placental invasion. You might see placenta previa because of the placental tethering, the parenchymal signal intensity and the presence of dark intraplacental bands are greater, more than normal, and they are irregular in thickness than the normal septation. Of course, this needs a little bit more practice. So basically, we look for any signs of bulging or rounded placental edges. We look for any rounded placental edges or bulging placental edges. We can see any heterogeneity, a presence of placenta previa, and we look for any prominent septations more than normal, the normal placenta. You can see again another example here. There is a presence of placenta previa, obviously, which is suspicious, and you look for the indistinguishable myometrium, very thin myometrium, and you can see the placenta here has lumpy or rounded borders. This is suspicious for placental invasion. You can see here also the same patient. There are areas in which the placenta is bulky, and it has rounded edges. It's previa, of course, and the myometrium is indistinct here. What else do we have here? Another example in which we can see the placenta here is bulky, lumpy. It has an irregular surface with abnormal myometrium. In general, we have, as we said, we have 3 grades of placenta accreta. This is placenta accreta, increta, and pericreta. So accreta and increta, we do not try too hard to distinguish between them because it will not affect the management. It's the same management. However, it's very important to distinguish placenta accreta and increta from placenta pericreta, because if this is placenta pericreta, if it's invading into the surrounding organs, then we need to have a different kind of surgery depending on the organ and the type and the depth of invasion that has happened. So in order to definitely diagnose placenta pericreta, we need additional features like full thickness gap of the myometrium, loss of the fatty signal intensity surrounding the uterus or surrounding other adjacent structures, or presence of irregularity in the wall of the urinary bladder or bowel wall or the abdominopelvic wall muscles. So we need other features to diagnose placenta pericreta. For example, you can see here, of course, this is a big lumpy placenta. It's placenta previa, it's covering the internal cervical os, and it has a prominent vascularity, more than normal, and you can see the septi are much more prominent. And if you look at the myometrium here, it's disrupted, it's lost here. There is no myometrium at all. This is invasion to the surrounding, to the myometrium and the surrounding soft tissues. It's reaching the abdominopelvic muscle walls. So this is a severe case of placenta pericreta. Another example here, you can see the myometrium is, I don't think it's distinguishable. And here it's completely invaded and eroded into the surrounding muscles. Now, another example, obviously here you can see it's a kind of placenta previa. It has a lumpy, rounded borders. The myometrium is ill-defined and it's not very well seen. So this is a case of placenta pericreta with invasion to the abdominal wall muscle. And if you look carefully, I think you'll even see some irregularity of the wall of the urinary bladder, suggesting possible urinary bladder invasion. Let's see this example here. Again, it's lumpy, it's rounded, the edges are not smooth, and it's thick with a prominent vascularity, and the myometrium is not very well differentiated. However, if you look here, it's eroded the myometrium and it's invading into the surrounding structures. Now, one of the things that we have to be sure about is there is no pitfall in diagnosis. There is no artifact or no something that might look like placenta accreta spectrum. First of all, we are dealing with a pregnant woman, so movement of the baby or of the mother is of a great problem, and that's why we need to use fast imaging sequences that are so fast before the baby or the fetus starts moving. For example, we can see here, this is a fast imaging sequence, and we can see the fetus there is no motion artifact here. I will not go into the proper imaging sequences. It's not beyond the scope of this episode. So we can see here the placenta, obviously, and we can see loss of the myometrium, and here possible invasion of the posterior of the soft tissues. Another example here, you can see this is a very nicely demonstrated placenta, and we can see the diffuse thinning of the myometrium and loss of the three-layer appearance. It has some lumpy areas here and there, so also suspicious for placenta accreta spectrum. And if we use a sequence with long imaging time, which is more like a standard kind of sequence that we use on normal adults all the time, we can see there is obvious irregularity and motion artifact and haziness here and there. And although this is placenta previa, and although we can see some disruption here and there, we can never be very sure that it's a spectrum of placenta accreta. Here is a more remarkable example. You can see the large motion artifact caused by the fetal movement, and it causes the irregularity in the placental and uterine junction or interface to be less appreciated, and you can see it's placenta previa and possibly invading the urinary bladder. However, the presence of motion artifact makes it not very well appreciated. And another imaging pitfall, if we do the MRI images after 30 weeks of gestation, we said the proper timing would be between 24 to 30 weeks of gestation. So, for example, after 30 weeks, this MRI image, we saw that the placenta was previa, of course, but there is no definite signs of invasion. The placenta is not very lumpy, not very, the borders are not very rounded, and there are some T2 septa here and there, which should be normal in advanced pregnancy, placenta after 30 weeks. So the presence of placenta pericrita was excluded. However, at surgery, it turns out to be placenta pericrita. So imaging after 30 weeks of gestation should be really careful with that. Another example here, advanced stage imaging at 30 weeks of, more than 30 weeks of gestation. You can see here presence of placenta accreta, increta, but unlikely to be placenta pericrita due to clear surrounding structures. And here there's the myometrium is a little bit distinguished if you look carefully here. However, this was placenta pericrita with invasion also. This was our talk for today. I hope you find it beneficial. See you later next week, inshallah, at 5 p.m. This was Dr. Ahmed D. Abdulwahab, and this is Highlights in Radiology. Bye-bye.